Unit 5 is about pain, inflammation, and fever. So pain, inflammation, and fever, they're common responses, and actually, for the most part, they're expected responses from different conditions, such as infection and other things going on in our body. So these responses may occur individually or together with one another. There are drug classes that are used to treat pain, inflammation, fever, along with applicable lab tests and patient education, and this will be discussed in this unit. These are your objectives. Again, for your exams, please make sure you review these objectives and make sure you're incorporating it while you're studying. And for your assignment, review physiology of pain, inflammation, and fever as needed, as well as these are the reading chapters that you can use to supplement your outlines. Pain. The definition of pain: unpleasant sensory and emotional experience associated with either actual or potential tissue damage. These are some terms that you have to remember. So first, analgesia. Analgesia is basically what we call medications that relieve pain without causing loss of consciousness. Equianalgesia or equidosing is basically the term that we use with doses of each opioid needed to provide the same relief. So it's the ability to provide equivalent pain relief by calculating dosages of different drugs or routes of administration. So examples of those, depending on what resources you're looking at, hydromorphone, or also called Dilaudid, is 5 times more potent than morphine. So an example of this is that if you give a patient 10 milligrams of morphine sulfate and then you give a patient 1 milligram of hydromorphone, the equivalent to that is receiving 15 milligrams of morphine sulfate. Another example would be giving a patient 0.1 milligrams or 100 micrograms of IV fentanyl. The equivalent to that is giving the patient 10 milligrams of morphine sulfate. So that's equianalgesia or equidosing. There are different kinds or types of pain. Neuropathic pain is pain that results from a disturbance of function in a nerve. So it's called neuropathy. There's also phantom pain. Phantom pain is experienced in the area of a body that has been surgically removed or it's no longer there. An example of this is when a patient, let's say with a right below the knee amputation, reports that the patient is having right foot pain when the foot is no longer there. Referred pain is pain occurring in an area away from the organ of origin. So an example to that is somebody having cholecystitis. One of the symptoms is that patients often complain of back or scapular pain. Well, we know that the gallbladder is far away from that area. So that's called referred pain. Somatic pain, on the other hand, is pain that originates from skeletal muscles, ligaments or joints, cramping, gnawing pain, bump knee, pain localized to the knee. So that's somatic. Vascular pain is pain that originates from pathology of the vascular or perivascular tissues, such as migraine headaches. Visceral pain, on the other hand, is pain that originates from organs or smooth muscle. So it's usually from pelvic or abdominal organs. Visceral structures are highly sensitive to distension or stretch. Ischemia, inflammation, and example of this includes pain that experienced during appendicitis, gallstones, diverticulitis, and pelvic pain. There are other kinds of pain as well. So one is a breakthrough pain. So breakthrough pain is pain that occurs between doses of pain medications. So an example is, let's say you give somebody an NSAID for long-acting pain, and then we use the opioid for the breakthrough pain. So when the pain medication is not due yet and the patient experiences pain in between those doses, that's what you call breakthrough pain. Terminal illness and disease is caused by the illness itself. So there's pain from terminal illness or disease. An example of this is pain from pressure of tumor mass against nerves, organs, tissues, or even due to the treatment of the illness. An example of this is such as cancer treatment. We can also classify pain based on timeline. So we have acute, chronic. So acute means sudden pain, usually subsides with treatment. Chronic, on the other hand, is persistent or reoccurring, which often lasts equal to or greater than 6 months. It's more difficult to treat due to changes that occur in the nervous system that often require increasing drug dosages. Effects of pain. So onset and duration are different. Tolerance, psychological element of pain, or pain threshold, that can affect that as well, and physical dependence can affect activities of daily living. Some potential issues related to pain include tolerance. So tolerance is basically from repetitive exposure to a given drug. So over time, it induces changes in the drug receptors that reduce the drug's effect. Somebody who's been on some pain medications for quite some time, they may need higher doses of the same medications that they've been receiving. So they basically develop tolerance. Dependence is basically referring to physical dependence. Although some people use dependence and addiction interchangeably, dependence is more of a physical dependence. So mentally, psychologically, the patient wants to be off the medication. However, physically, they're unable to be off such medication. On the other hand, addiction is psychological dependence. So it's a change in behavior caused by biochemical changes in the brain after continuous substance use, and substance becomes the main priority of a person who's addicted to these medications. So again, dependence and addictions are different, although some people will use it interchangeably. Dependence, there's sometimes willingness to be off the medication, however, the body becomes dependent. Meanwhile, addiction, you don't necessarily have physical dependence. It's mostly psychological in nature. Nursing actions. So we have, in our assessments, we have some rating scales. So these are scales meant to rate the pain level. So there are different kinds depending on the patient, right, age group, and sometimes it's also dependent on the facility itself. So this is an example of a numeric pain scale. So this is what we often see or use at the hospitals. So it's the scale that's 0 to 10. So 0 being none and 10 worse pain or severe pain. As you can see, it's rated from 0 to 10 scale. We also have phases, pain assessment. So sometimes some people are unable to state the number, but they're able to choose the phases that would closely describe their pain level. And we also have flag pain scale. It's often used for patients who are nonverbal or unable to communicate their pain levels. And flag scale is basically derived from face, legs, activity, cry, and consolability. So as you can see, depending on their facial expressions, right, there's a designated number equivalent to that, as well as movement of the legs, activity, cry, and consolability. And depending on that, they add it all together, and that's the patient's pain level. Pain is basically whatever the patient says it is, right? So we can't really say, oh no, you're not in pain, and certain patients will have different responses. But there are also associated changes to vital signs, activity, and affect when it comes to pain. Again, sometimes these indicators can be unreliable, and also it is very difficult to really assess. At the same time, also we need to take in consideration our own biases, right? So sometimes some nurses just believe that certain patients are not having pain while they're actually in pain. So we have to be very careful with that. Anyhow, that being said, vital signs. So sometimes pain can affect the vital signs. So commonly when patient is in pain, the heart rate goes up. Blood pressure can go up because of pain. Now, activity levels. So sometimes we can tell when a patient is in pain based on their activity, especially if you have somebody who, let's say, a very active patient, walks every day, and then all of a sudden today they're not wanting to move, they're not wanting to get out of bed, they're not cooperating with physical therapy. That may be an indication of patient's pain. Affect or expression of emotion. So sometimes, and this can be also based on culture, some patients won't look at you when they're in pain. Some patients are more vocal, so some patients will cry, but they're also culturally patients who will not show any emotion even if they're in pain. So those are the things also that we need to take in consideration, because sometimes we think, oh, the patient is not in pain because they're not crying or they're not grimacing, but it may be something cultural, or it may be something that's within the patient's values or their personality. Like they don't want to show somebody that they're in pain. So those are the things that we need to keep an eye. But sometimes affect can give us an idea of the patient's pain. Psychological effect of pain, especially with this one, chronic pain. Chronic pain can affect the patient psychologically. So that can cause a lot of depression. So that's very common, and sometimes anxiety in anticipation of certain things. Because if they know that previously that caused pain, some patients will be very anxious and restless prior to, let's say, going to the dentist, right? Prior to doing dressing changes. If previously that a patient experienced excruciating pain during dressing changes, guess what? That can cause anxiety just in anticipation. But again, one of the common things that we see is actually depression, especially in chronic pain. So part of the plan of care, we have acute, chronic, or acute on chronic pain. We also have knowledge base of the nurse, assessments and treatment. So depending, sometimes it is also important to have adequate knowledge on how to treat or address pain. Knowledge base of patient and family. And that's also something that we need to consider, especially somebody who's going home, or if we know that when they go home, they need somebody that will take care of them. So it is very important for the patient and family to know the uses of the medication, some side effects, results, and it is very important to have appropriate management. So goals must be realistic and measurable. And when we say measurable, it also has to have a time frame. And we also need to base it on the patient's level of tolerance, because sometimes some patients will be okay with a pain of 5. Meanwhile, other patients will say pain of 5 is too much for them to handle. And again, realistic and measurable. For somebody who's post-op, if somebody just, let's say, had a knee surgery, right? It is almost impossible to say that our goal is for the patient to have zero pain with activity, right? So we need to be realistic and just having and educate the patient to have realistic expectations as well. Because if we tell them that we're able to achieve zero pain and they have a pain of 1 or 2, it actually affects on how they perceive pain, and it may feel worse. Meanwhile, if you tell them it is expected to have pain, then they have a little different of an outlook when, let's say, they're doing physical therapy or certain activities after surgery. So again, when we're setting our goals and also when we're educating our patients, we need to be realistic and it needs to be measurable. And so that's where we need to make sure that we have a time frame, and also, if possible, if we can use one of the pain scales that we discussed previously. So available treatments, most of the time we rely on pharmacological treatment, which is, I don't see that it's completely wrong, but we also have to remember that there's non-pharmacological treatment, because pharmacological treatment, as you recall, there are possible side effects, and especially for controlled substances or opioids or narcotics, it can possibly lead to dependence. So we want to make sure, if we can, combine pharmacological and non-pharmacological means of managing pain. So implementation and evaluation, these are very important steps of the nursing process. So if somebody is experiencing pain and then we plan to control the pain, when it comes to implementation, an example is, let's say, administering an analgesic. Part of the process is, let's say, depending on what medication we're talking about, 30 minutes, an hour later, we need to go back and evaluate. So reassess the patient to make sure that, one, is it effective? Are we controlling the pain? Do we need to adjust the dose, right? There's no way to finding out unless we go back and reassess the patient or evaluate for the effectiveness or lack thereof. In addition to that, it's also important to evaluate the patient, because also we want to know, is the patient experiencing some side effects? So if we give somebody morphine, let's say morphine 10 milligrams, and then we come back and the patient is very drowsy, unable to stay awake, that's a side effect of the medication. So that's going to be something that we want to evaluate for. Biases. What are some biases or perceptions nurses have? So we have to be very careful with this. We have to really try our best to assess, evaluate ourselves, and reflect what are our biases, and hopefully based on that, we're able to look beyond that and truly assess our patients and figure out if really the patient is in pain. Because sometimes our biases can interfere with our ability to really help our patients, especially, for example, our young patients. So sometimes they go to the hospital, let's say they're in severe pain, but at times nurses, because of their own biases, they automatically think that these patients are pain seeking, that they just want controlled substances, pain medications, or they're addicted, while in fact they're actually in real pain. So again, please be very careful with your biases, and hopefully that does not interfere with your ability to help or treat somebody's pain. There are also non-pharmacological treatments for pain, and it is also important to incorporate them. It's going to be dependent on the patient, so we also want to make sure, is this safe? Is this appropriate? Are we doing this in the right time? Examples include massage. So depending on the location, is this safe for a patient? Example, let's say, of a safe massage would be if somebody's just having muscle spasm and you want to massage the area, that should be okay, right? But let's say somebody having cuff pain and the patient has DVT or deep vein thrombosis, that may not be a safe treatment for the patient. So definitely take in consideration if this is appropriate or safe for the patient. We also have heat or cold therapy. For the most part, we need some orders. And again, is this safe for the patient, right? So one thing to consider, it doesn't mean that we can do it, that we should always do it without considering what is actually going on with the patient. Because you may have somebody in pain, let's say they're having fever. It wouldn't be appropriate for somebody to, let's say, put heat compresses when the patient is already running a fever. Take that in consideration. Is it safe? Is it appropriate for your specific patient? We also have imagery. So this is often used in labor and delivery. And imagery is basically focusing on positive or pleasant images for the patient. So in here, patients use their senses to, let's say, imagining the breeze, the bright blue of the water, and all those things to take their mind off of the pain. We also have biofeedback. This is often done outpatient. So in here, patients are provided with situations. The therapist guides the patient through relaxation techniques. This is often used with hypertension, tension headaches, chronic pain, and also we have acupuncture. So acupuncture, again, this is also done outpatient. And for some patients, especially patients with chronic pain, they do report that they benefit from acupuncture.